Hi there, my name is Griffin. I'm a research fellow with the School of Public Health at University College Cork. And my presentation today is factors explaining variation in recommended care pathways following hospital presenting self-harm. It's a multi-level national registry study. And just to flag that subsequently this study has been published in the BJ Psych Open. So each year, more than 12,000 presentations due to self-harm are made to Irish hospital emergency departments, representing a rate of about 200 per 100,000. Now, these represent a really important clinical group, particularly in terms of suicide prevention, given that self-harm is the biggest predictor of suicide. And of these presentations, approximately 30% will be followed by a subsequent presentation within 12 months. So a number of countries, including the UK, have developed clinical guidelines and quality standards for the short-term management of self-harm in hospital settings. And these guidelines include recommending that the provision of a comprehensive psychosocial assessment of a patient's psychosocial needs and mental health status at the time of presentation to hospital. However, evidence for adherence to and implementation of these guidelines is quite poor. A study from the UK a number of years ago found that assessment rates vary considerably across hospitals, as well as other pathways following hospital attendance, including admission rates. So this is significant, and there's evidence to suggest that the treatments that are received in the emergency department and in the hospital are associated with patterns of subsequent repetition. And furthermore, a lack of standardized care or poor quality of care can have a significant negative impact for individuals and may actually increase suicidal risk, or perhaps discourage somebody from seeking help again. And here we have a number of quotes from a mixed method study that was published last year on patients' experiences of presenting to hospital following self-harm. And you can see here just a couple of examples. So that they found that their interaction with the staff was particularly harsh, and that the person was not very understanding. And when you're feeling really vulnerable, a little bit of empathy would go a long way. And also highlighting challenges in relation to consistency in relation to mental health staff. I see a different person every time, which is annoying because then you have to go through everything all over again. So to date, studies which have examined clinical pathways following self-harm and what influences the treatment that a person receives have primarily focused on factors at a patient level, and common factors which emerge from the literature include age, gender, severity of self-harm, a person's self-harm history, and the time that they present to hospital. A study that we published back in 2018 found that the hospital person presents to dictates their treatment beyond their medical and psychiatric needs. However, we don't have a clear idea, well, what are the specific hospital factors that contribute to this? So in this current study, we use data from the National Self-Harm Registry in Ireland to identify factors at a hospital level contributing to the care pathways following self-harm using 4 common outcomes. So our study design, as I mentioned, our study is based on data from the National Self-Harm Registry Ireland. Ireland has a population of just under 5 million people, and there are 26 acute hospitals which provide 24-hour emergency department cover. And we use data from these hospitals for the years 2017 and 2018, and we limited our sample to those aged 18 years and over. As I mentioned, we examined 4 common outcomes in terms of clinical care pathways following self-harm. The first is self-discharge, and here we included where an individual may be registered at the hospital or were triaged but left before their care could be completed, or they left before a decision could be made regarding recommended next care. We also looked at medical admission, so whether a person was admitted into a general ward of the presenting hospital, and this includes a small number of cases where a person, where it was recommended a person be admitted, but they refused that option. Psychiatric admission then again to the presenting hospital. So what wasn't included here were psychiatric admissions to other non-acute settings. And finally, psychosocial assessment by a mental health professional. And as people admitted into hospital may have an assessment at a later time during their stay, and this generally isn't recorded by the registry, so we limited this outcome to individuals who are discharged from the ED following their treatment. And so in terms of analyses, we ran 4 separate multi-level Boston regression models for each of the outcomes, generating incidence rate ratios and 95% confidence intervals. And we ran these models in 2 ways. First of all, we used a backward method to enter the variables beginning with the hospital level factors and then moving on to patient level factors. So variables which were not strongly associated with the outcome, and we used a cutoff here of p less than 0.05, were removed sequentially until only the variables that were strongly associated with the outcome remained. And given the large number of factors examined, we also did the sensitivity analysis where we used a forward stepwise method, and we found that similar variables were observed both ways. So here's a list of the hospital and patient level factors that we considered. So we gathered as much information as we could at a hospital level, including mental health resources in the hospital and more general hospital factors as well. We use a hospital admission rate, which is a conversion rate from ED attendance to ED admission as a type of measure of turnover. And we included this factor for both general ED attendances and admissions for any reason, and separately for self-harm. And at level 2, at the patient level, here's a list of the items that we included, including gender, age, whether an individual had a medical card, which would entitle them to free healthcare in Ireland, the time and day of presentation, and whether alcohol was involved, and methods of self-harm were coded using ICD code 60 to X84. We also used socioeconomic deprivation based on the person's area of residence, and also whether a person was admitted to an ED observation unit as part of their stay. Just to run through some of the sample characteristics, over this 2-year period, there were 14,555 self-harm presentations recorded. About half the sample were female, and the mean age was about 32 years. In terms of method of self-harm, more than half of presentations were due to an intentional drug overdose, which generally reflects hospital samples in relation to self-harm. And just to take you through the clinical care pathways that we recorded within the sample. So of the total sample, about 12% of individuals self-discharged. As I said, maybe left before their care was completed or left before a decision was made regarding next care. Of those who did not self-discharge, more than a quarter, so 28% were admitted to a medical ward, and a further 8% were admitted to a psychiatric ward. And of those who did not self-discharge, the majority were discharged from the ED following completion of their treatment. And of those, 83% received a psychosocial assessment. So this is quite a high proportion of individuals receiving a psychosocial assessment. In some other estimates, in some other studies, it could be as low as 40 or 50%. And so these funnel plots really serve to illustrate the variation in these 4 outcomes by hospital. And here the funnel plots plot this variation relative to the size of each hospital in terms of the number of self-harm presentations that are made every year. So the self-discharge rate, which is on the top left-hand corner, ranged from 5 to 18%, and there is some, but not huge variation by hospital. The medical and psychiatric admission rates range from 8 to 53% and from 0.3 to 28% respectively, and you can see that there is variation by hospital. And for psychosocial assessments, we see again considerable variation by hospital, and these rates range from 17 to 97%. So quite a high range there, quite a wide range. So on to the results of the multi-level model. And the full paper shows a breakdown of significant patient and hospital factors, but I'm just going to focus on the hospital factors in the interest of brevity, and we'll summarize the main take-home messages. And these are all the hospital measures that were significant in the final models. So for self-discharge, for medical and psychiatric admission, the identified factors were largely a mix of patient and hospital factors, which probably would be expected and reflect the complexity of these self-harm presentations. However, whether an individual received a psychosocial assessment, which, as I mentioned, is the minimum standard of care for every presentation, this was almost fully explained by hospital factors, and actually the only patient-level factor which was significant was whether a person was admitted to an ED observation unit. So the first variable here, a hospital self-harm admission rate, was associated with all the outcomes. And this probably indicates some sort of underlying policy at a hospital level in terms of management of self-harm. So for example, the lower risk of psychiatric admission and receipt of a psychosocial assessment in hospitals with high rates of self-harm admissions may indicate a policy to admit patients in the short term for the purposes of completing psychiatric reviews and psychiatric care. And this is further supported by the findings with regards to admission to ED observation units, which resulted then in fewer subsequent admissions for both medical and psychiatric care, and also increased provision of psychosocial assessments. In addition, psychiatric on-site facilities and having a dedicated self-harm nurse increase psychiatric admissions at the time of presentation. So to summarize, we found that for psychosocial assessments, almost all of the variation was explained at the hospital level. This is interesting as other research has identified patient factors, including method and history as primary factors, and our findings would indicate that whether a person receives an assessment is not down to perceived suicidal risk or the profile of the patient, but rather due to mental health resources, particularly the availability of psychiatric facilities. Further research is really required to unpack hospital policies for admitting presentations of self-harm and the impacts of these. On one hand, short-term medical admission may result in increased assessments and decreased medical complications and a shorter length of stay. However, alternatively, hospitals may admit patients to receive service completion targets and to offset the pressures of completing care within a 4 or a 6 hour target, and particularly in complex cases. So our data suggests that the use of ED observation units may help in the process of conducting parallel medical and mental health care, and may actually reduce short-term admissions. We didn't have data to examine length of stay, but other research could also consider the value of these dedicated or of other dedicated spaces in the EDs for mental health resources. To account for the fact that self-harm presentations were made to largely heterogeneous emergency departments, we included several hospital measures reflecting both mental health resources and the profile of the hospital more generally, but these general hospital factors did not make a significant contribution, and in particular, provision of on-site mental health facilities and the availability of specialised mental health staff has a strong impact on psychiatric-related care. So the strengths of our study is that we had full coverage via national registry, accurate data on hospital factors corresponding to the study period, and we use multi-level model techniques. Now, the interclass correlation statistics that we generated show that their models accounted for a large amount of variation at the hospital level, but not all. And so some of this residual variation may be explained by data that we did not have access to. So for example, more detailed information on staffing and resourcing. So to summarize, emergency departments provide a unique opportunity for suicide prevention in order to provide interventions and care to people who are at high risk of suicide. But in order to do that, timely and high quality care is needed and based on the principle of compassion, and it needs to be responsive to individuals' needs. This requires a coordinated response in terms of both medical and psychosocial needs, and initiatives should seek to achieve this. So for example, mental health triage systems should be, and their use should be evaluated. So while self-harm presentations represent a small proportion of all ED presentations, they are high risk. And so mental health resources need to be considered in the overall allocation of hospital resources. And given that variation is largely driven by the resources and underlying policies, future research might consider how these policies are developed and implemented and how we might better seek to coordinate and standardize care. So thank you very much. Here are my contact details. I'd like to acknowledge my co-authors, Professor David Gunnell and Dr. Paul Corcoran. And this research is part of an ongoing project supported by the Health Research Board. Thank you.